against silicone injections continue, and here with us today is board-certified plastic surgeon Dr. Timothy Katzen, who will be speaking to us about the dangers of silicone injections and what to do if you have them. Dr. Katzen?
So thanks, Ariel. My name is Dr. Katzen, and I specialize in silicone removal. And we're here at the Institute of Silicone Removal to discuss with you the problems and the implications and the solutions to silicone removal. So I got into this field because so many people have had silicone and other foreign bodies injected into their buttocks and other body parts, and these are toxic substances which cause a whole host of problems. So today's lecture is going to pretty much focus on silicone and other foreign bodies that have been injected into the buttocks. So when people come to me, they say, oh, I've had stuff injected into my buttocks. And most of the time, the person doesn't really know what's been injected into the buttock. The person that's injecting them is the only person that really knows what's been injected. But this stuff that gets injected goes by many, many names. People call it biopolymer, PMMA, body oil collagen, butt shot, silicone 1000, aquafil, atrafil, hydrophil. There are all these names that the products go by, but most of the time that stuff that's being injected illegal is silicone. So here at the Institute, we've found many products that have been injected. So these are just a small array of the products that we've seen here at the Institute of Silicone Removal being injected into patients. So the injector literally goes sometimes to the hardware store and gets these products. Again, the most common product is silicone, but here at the Institute we've seen actually nails, liquid nails injected. We have also seen quite commonly a product called Crazy Glue, methyl cyanoacrylate. We've seen cod liver oil and oils injected. We've also seen polyurethane injected. We've also seen spackling and cement injected. We've actually even seen motor oil injected into the buttock. And sometimes the injector will actually go to the patient, my patients tell me this, and say, oh, it's an all-natural product. Look, here it is, here's silicone, it's all natural. They dip their finger into it, they go like that to the patient going, look, it's natural, it's perfectly safe because look, I can eat it. So does that make it safe? Absolutely not. So these are just some of the products that we see that are injected, and again, it goes by many, many different names. But all these products are illegal, not medical grade, not FDA approved. So what was really injected, most of us will never know. Only the injector really knows. But again, usually it's that silicone product. We've also seen sometimes fiberglass. Fiberglass is injected, that's really bad. Tire sealant, Fix-A-Flat, the caulking, the Crazy Glue, the acrylic. All in all, it's just really, really bad stuff. So what happens when that stuff is injected? First, there's an inflammatory response, and that happens within minutes of the injection. Now, some patients, when they're injected, the inflammatory response is so severe that they die in the injector's hands. They literally collapse. They don't even have time for a 911 call. Sometimes the immune reaction won't be that strong and they're able to call 911 and in fact get to the hospital and be treated. But a lot of those cases actually die because there's a massive pulmonary embolus or a blood clot. But if you survive that injection period, what happens is the body develops an immune response. Basically, it recognizes that it's not you and causes inflammation. What it does is it rushes blood cells to the area, which cause redness. Then you get swelling in that area. And the itching is due to a specific cell in the human body called a mast cell, which releases histamine. It's part of the normal cascade of the inflammatory response. So the itching is due to a histamine response. And that causes the itchy skin, and that causes reactions on the skin. So what happens next is this analogy that I'm going to do with the Play-Doh. So this is the silicone that's been injected into your body. And your body quickly realizes that this is not you and forms an inflammatory response to try to react to this. So once it realizes it's not you, causes inflammation, causes swelling, release of histamine, and then it makes scar tissue around it. It wants to wall off this object. So what it does is, if this is the silicone, then it forms this wrapper of scar tissue and envelops and completely surrounds this ball of silicone. And initially that's good and fine, but over time the body keeps on making more and more scar tissue around this little ball of silicone. So year after year, it keeps adding more and more scar to this ball of silicone. Till after about 10-15 years, it's this giant ball of scar tissue with underlying silicone underneath. And then once it's balled up, then the body is like, okay, how do we get rid of this thing? And what it does is it then tries to liquefy the area between this ball and the skin. So it tries to migrate up here by liquefying all the skin. And then the skin sends messages to the mass below that we're ready, so the skin actually goes through a lot of changes also. So what happens is that the scar forms these lumps, and you can actually feel them underneath the skin. They appear initially very small, and then they become larger, and then they coalesce into one big large lump on your buttocks and or your thighs. One of the problems too, this scar tissue, this pink object here, is made of calcium. So sometimes there's so much calcium and so much scar tissue in there that actually the calcium in your blood starts to get very elevated and can lead to a whole host of problems. Kidney stones, kidney failure, blockage in your arteries, blockage in your veins, just because of that elevated calcium. So this scar tissue is not a good thing. All right, so what happens is when the injector injects foreign product or foreign substance, usually silicone, it's injected underneath the skin. And usually it goes in the fatty layer. Sometimes the injector, maybe on purpose or accidentally, it actually goes into the muscle, but more about that later. So once this foreign product is inside your body reacts, inflammatory response, redness, swelling, histamine, itching, etc. And then your body makes primitive or sort of juvenile scar tissue around all these little, we call them bobas because they sort of look like bobas, little balls of silicone. They're also called siliconomas because they're balls of silicone. So your body makes all this scar tissue around all these little balls of silicone, and that's what its initial reaction is. So sometimes immediately after the surgery, you'll have pain in that area as the inflammatory response sets up. And then over the next couple of months or maybe even years, you notice these hard masses that develop over the balls of silicone or foreign body. And what happens is, over time, your body makes more and more scar tissue to these areas. It just slowly builds upon these, and the balls of silicone and the scar tissue, sort of like a snowball going down a mountain. They get bigger and bigger, and they start to coalesce and go together into one big giant ball of scar tissue and silicone. So that's what happens as time goes on. Buttocks get bigger and bigger, not necessarily because the silicone's getting larger. Silicone can't grow. It's that the scar tissue is getting bigger and bigger and bigger around the silicone. So one of the things that happens is as the scar tissue gets bigger and bigger, it starts to expand, making your buttock bigger, and it starts to press on neighboring structures, specifically nerves. So in this demonstration, this is a nerve in your lower back called the sciatic nerve. And as these injections spread, they get bigger and bigger and start pressing on the nerve. So there's actual physical compression on this nerve, denting the nerve, giving you buttock pain, giving you back of the thigh pain, giving you pain down your leg, getting you a numb leg. Sometimes also this scar tissue can get so thick it starts to wrap around the nerve, sort of like roots on a tree, which can also compress the nerve. And also the sheer presence of silicone next to a nerve, just like that, makes this nerve angry. We've done a lot of studies, and you can put silicone just close to a nerve, makes this nerve very angry and irritated, so it causes a lot of localized pain and pain that radiates down the leg. So the way I look at things, you have the microenvironment and the macroenvironment. To me, that means there's stuff you cannot see, that's the microenvironment, and the macroenvironment means things you can see. So the microenvironment really is what's going on in the bloodstream, in the circulation, what's silicone causing. And the macro is these clinical symptoms of pain, that's the silicone pressing against the nerve, the skin changes, and also this product, both the product, silicone, and the scar tissue, the whole thing can migrate and move around. So let's look at the microenvironment first. And again, the microenvironment is what's going on in the blood. Now, when silicone is injected, it's a foreign body. So your body is like, whoa, what is this stuff? And it causes this foreign body reaction. And basically, it can cross-react with a lot of other stuff. So your body sees the silicone and makes all this scar tissue. But your body is not 100% accurate. So sometimes when it starts attacking the silicone, it cross-reacts with some of your normal tissue in your thyroid, in some of your blood vessels, and all these other body parts, and it can cause all these associated autoimmune problems like Addison's disease, like antiphospholipid syndrome, and all these other conditions, celiac, Graves, Guillain-Barré, Hashimoto's thyroiditis. And this is just a partial list of 15 things, rheumatoid arthritis there at the bottom. So here's a second list of another 15 diseases which can be caused by this autoimmune process where your body's cross-reacting with the silicone. Sarcoidosis, scleroderma, lupus, vasculitis, where your blood vessels are inflamed. It can cause high blood pressure, hypertension, rheumatoid arthritis again, psoriasis, templar arteritis, and all these other autoimmune problems which are thought to be related to the cross-reactivity of your body reacting to the silicone and then also reacting against all your other normal body parts. So when I see a patient for a workup for autoimmune problems related to the silicone, there are a whole host of blood labs that I order. And among them will be the complete blood counts, the ESR, erythrocyte sedimentation rate, antinuclear antibodies, C-reactive proteins, protein kinases, IgA, IgG, IgM, IFA, a whole host of blood panels where we look at specific reactions of your body to this product. We also look at the thyroid. Thyroid is very common cross-reactivity to the silicone for some unknown reason. Your body makes an antibody to the silicone, and it also cross-reacts with the thyroid, and it can give you a whole host of thyroid problems. So we order thyroid panels and some specific labs where we look at the thyroid, the antibodies, and the anti-TPO. We also look at the cross-reactivity with the silicone and the cardiovascular system. So we also get these blood panels looking specifically at the heart and the vascular system. And also the neurologic markers we look at, we also order these specific type of antibodies. Now, that's what's going on in the blood and the circulation. Now, what do we look at when we have patients come in the office? We're looking at the macro, the things you can see. So the macro environment or climate of the silicone can be skin changes. And what's happening here is that the silicoma, the granuloma, the ball of scar tissue that's wrapped around the silicone is trying to get out of the skin. Initially, you may have some inflammatory responses where it's mild, it's red, it's itchy. But as time goes on, these areas get bigger and bigger, and the masses try to come out through the skin, and it's been more chronic, so the skin has sort of had some time to react to the underlying silicoma or granuloma, and you get these skin changes. And the skin basically starts to thin. It looks like tissue paper almost, and to us we call it, and my patients call it, alligator skin, because that's sort of what it looks like. And typically you can get it in the buttock crack as the silicone is migrating through the skin and trying to get out of the skin, and you get these areas of, we call it peu d'orange, which is basically orange skin in the buttock crack on both sides. And you can see a variety of patients here where they get this alligator skin due to the silicone that's being injected and the granulomas, silicomas that are trying to come out. And then it can become even more severe, where the granuloma and the silicone is trying to eject through the skin. And I have actually some patients who come to the exam room, and when they sit down on the exam room table, the silicone is literally leaking out of their buttock and it's sticking to the table. So here are more severe cases where the silicone is actually leaching, it's actually going through the skin and staining the skin also. So these are more extreme cases of silicone contamination of the silicone trying to get out. So there are normal fillers and silicone fillers. Now, normal fillers are FDA approved, they've been studied in patients, they've been studied in animals, and we've deemed them to be very safe. And usually those are, to some extent, dissolvable. Over time, they will disappear. May take 8 months, may take a year, maybe even take 2 years, or maybe 3, on the outside 4 years. Silicone, on the other hand, is not FDA approved for body contouring. It will not degrade. It's a permanent filler. It will not go away. It's not a good idea to use this when you're trying to fill body parts like the buttocks. One of the things we see very commonly in the clinical practice in terms of the macro environment of silicone, in addition to the skin changes, is pain. And that's because this silicoma, this granuloma, all the scar tissue is either next to the nerve, pressing on the nerve, or in fact surrounding the nerve like roots on a tree and causing direct pain right there, and then radiating pain in the buttock, lower buttock, thigh, and even in the foot. And the silicone actively causes an inflammatory response. Once it's injected, your body is sort of trained and it knows to say, oh my gosh, red alert, send in the troops, basically just cause an inflammatory response, rush blood to the area, make it swollen, elicit an immune reaction to it. So you'll get swelling. And we know from all our studies that if you put silicone just close to a nerve, it will cause the nerve to get angry, both localized pain. And then as the silicoma gets larger and larger, it starts to press on the nerve. And as the scar tissue gets even larger and larger, it wraps around the nerve. So we have a lot of patients come to the office complaining of low back pain, and sometimes they don't remember that, oh yeah, we had something injected into the buttock which may be causing the pain. So what's happening there is that silicone is migrating, that's encapsulated with the scar, to the lower back. There's a lymph node channel at the top of the buttock crack in the low back, which can cause inflammation and lead to a lot of low back pain. Also, that granuloma can also start to press on some of those nerves in the lower back. And sometimes when we do the surgery, we have to actually take that nerve and piece out and peel out that scar tissue in that silicone. Now, a lot of patients will come into the office complaining of thigh and leg pain. Doc, my leg is numb, it falls asleep all the time. Whenever I get out of bed or whenever I've been sitting for a while, when I stand up, my legs are wobbly and numb. And that's because the silicone is pressing on that sciatic nerve. The sciatic nerve is that nerve that goes out through the buttock muscles, down the back of the leg, and innervates the leg. So when there's stuff injected into the buttocks, that stuff and the scar tissue can press on the nerve, giving you localized pain in the buttock, pain in the back of the thigh, and pain that radiates down the back of the leg. Then another problem is we have a lot of patients who come to the office complaining of, oh, I've got this lump in my groin. Oh, I have this lump in my knee. I have this lump in my ankle. And they don't quite realize that, oh yeah, I had silicone injected into the buttock and it may have migrated. So not only is this stuff injected, that's bad, but it also then moves around inside your body. And what happens is this silicone, presumably silicone or any other foreign body, jumps into the lymphatic channels. And lymphatic channels basically are a circulatory system in your body that filters the blood. And basically it has blocks, it has walls in the armpits and in the groin to prevent blood from going or bad things from going into your core, your peritoneal cavity and your chest cavity. So when there is a tumor, when there's a virus, when there's a bacterial infection, those lymph nodes inflame, that wall gets larger to wall off further spread inside your body. So when the silicone gets into the lymphatic system, it pools up in the lymph nodes. So sometimes when patients have product injected into the buttock, it goes around the hips and then goes into the groin lymph nodes. We see that a lot. Sometimes the product that's in the buttock also goes down underneath the buttock into the labia and the scrotum. Sometimes the product goes north into the lymphatic systems in the low back. And sometimes when patients have product injected into the breast, it actually goes into the armpit lymph nodes. Also, we have patients who have product injected into their face, the malar region, and sometimes we can see that product migrating down to the chin. So we have a lot of patients too that have product that's injected into the buttock and it migrates into the groin, the knee, and even to the ankles. So in this patient, she has an extreme case where you can see the pooling of the silicone that's in her ankles. This is not swelling. This is actually silicone that's migrated from her buttock to her ankles over 15 years. Other problems you can have with the silicomas are basically what I call GSCC. That's granulomas, that's balls of scar, granulation tissue. Siliconomas, that's basically a ball of scar around silicone. And also, what happens is as this scar tissue develops over and over, it's getting bigger and bigger and bigger and bigger over years and years, The body is not 100% perfect. So in its attempt to make the scar tissue, sometimes there are mistakes in the replication, in the duplication, in the creation of the scar tissue, and those mistakes can actually turn into cancers. So there are some patients who, with the silicone in place for a long enough time and with enough tissue, actually the silicone and scar tissue can change or mutate into certain types of cancers. So the G is for granulomas, the S is for silicomas, the C is for cancer, and then also with all this scar tissue, the body can also develop a lot of excess calcium, and the calcium can lead to really bad kidney stones and circulatory problems. The kidney stones can become so bad it can cause kidney failure, and my patients can even wind up on the kidney transplant list because the calcium levels are so high. So, what do I do with the silicone and the granulomas and the stuff that's been injected into the buttock? Well, you need to work it up. We need to figure out where it is and then what to do about it. So a lot of physicians who aren't knowledgeable on the subject may order an ultrasound or a CT scan, but those do nothing. The ultrasound won't really tell you anything. The CT scan may see the calcium or the scar tissue around the silicoma, but really won't tell you if it's in the muscle or to what extent it is in the soft tissue. So the best thing to get is an MRI. And the best type of MRI to get is of the pelvis, if that's where we're looking, and the hips and the thighs, with and without contrast. The MRIs with and without contrast help us to delineate the soft tissue, where the silicone is and where it is not. So, if you have silicone and granulomas in there, what should you do about it? Now, again, a lot of clinicians aren't too knowledgeable on the subject, so they may give you some antibiotics. Well, that's not going to get rid of the silicone. Okay, it may decrease the inflammatory response or maybe some of the bacteria that's on top of the scar tissue, but it's not going to treat the underlying problem of silicone. Some physicians will give you steroid shots, which does not get rid of the product. It only decreases the inflammatory response and delays the problem, okay? Delays the immune reaction of the silicone underneath. Some unknowledgeable doctors will also inject hyaluronidase in an attempt to dissolve the scar tissue. That's not going to work either. The only way to get the granulomas out with the silicone inside is with surgery. Okay, the surgery is the only option, and it will not go away on its own. So in this analogy, this is a ball of silicone, and the pink is the scar tissue that is wrapped around the ball of silicone. So a lot of my patients ask me, and some other physicians will ask me, when should you have surgery? In my opinion, as soon as you have the injection, you should have it removed, or ideally you shouldn't have it even injected to begin with. But if it is injected, try to get it out as soon as possible. A lot of physicians, in my opinion, mistakenly tell patients, just wait till you have problems. Don't operate on it, it's too difficult, or even worse, don't even have surgery because there's no good alternative for it. I strongly disagree. So you should get the product removed as soon as you can. All right. Silicone's permanent. It's not going away. It's not going to magically dissolve with antibiotics, steroids, hyaluronidase, Kenalog. It's here to stay. The only way to remove it is with surgery. So how do you get the silicone and the associated granuloma or silicone out? Okay, there are two ways to do it, what I call the closed technique and the open technique. Now, the closed technique is done through 3 limited incisions, one at the top of the buttock crack and one underneath each buttock crack. And those are ideal for patients who have a couple of little lumps here and there that are pretty small, I would say about the size of a small marble, that are scattered throughout the buttock, very small lumps. The lumps should be very soft because that tells me there's not a lot of thick granulation tissue, and it's just maybe a thin shell of scar around the silicone. And basically, this closed technique is good for patients who want the product out and cannot, for one reason or another, undergo the larger incision. In my opinion, it's better to get as much of the product out as you can than to leave it behind just because you don't want to have surgery. So a lot of my patients will ask me, well, when do I really need the incision, the cut? And that's really when the silicone is inside the gluteus maximus muscle Well, how do we tell? We get that MRI with and without contrast to tell where that silicone is. Is it above the muscle, gluteus maximus muscle, or is it below the muscle? If it's in the muscle, below the muscle, you really need to open cut. And then if the granulomas, the balls, are greater than 2 centimeters, you really should have the open. What is 2 centimeters? It's usually about the width of my thumb. If you have skin changes, then you should probably have the cut, the incision. And if your buttock is sagging, perhaps the silicone's been in there for a long time and the fat has atrophied and the skin is thin and the buttocks are really sagging, you'll probably do better with the incision, because with the incision, then I can also lift the buttock. Now, the open technique is ideal for patients who have large lumps and bumps. They have buttock pain, they have low back pain, and they have radiating pain down the thigh. That means to tell me that that scar tissue is wrapped around the muscle, it's wrapped around the nerve, so we really have to eradicate and peel that scar tissue that's on the nerve and on the muscle with the open technique where I make the incision. Now, the closed technique sort of came in evolution. I've been doing this for about 20 years because initially liposuction didn't work. We'd like liposuction to work, and I agree that liposuction does not work. But I've refined and refined and refined the liposuction technique so it does work on limited patients with silicone. So one of the problems with silicone is it moves around. We talked about that, migration. So when patients come to see me and they're face down on the operating room table, sometimes it's hard to find if you're not doing the open technique. If you're doing the open technique, it's obvious, it's right there, we remove it. But if you're doing a closed technique and you have 3 limited incisions, top of the buttock crack, underneath each buttock cheek, and you're trying to locate where the silicone is, I came up with this idea, well, why don't we use an intraoperative, during the surgery, live ultrasound. With the ultrasound, we can see exactly where these bobas are along the skin. So that was the first big improvement upon sort of traditional liposuction to remove these bobas or these silicomas. One, using an ultrasound to see where it is. Okay. Once you know where it is, then we have to crack this shell to get the scar tissue out, as well as the silicone that's inside. The silicone's pretty soft. It's the scar tissue around the outside that's really hard. And when you use a traditional liposuction machine, it cannot crack that shell. It cannot go through that. It cannot break through that. So what I do is I come in with a Vaser, and the Vaser cracks all this scar tissue up and splinters it up into little tiny pieces. So when I come along next with my cannula, I can suck out these little balls of scar, and those go up in the cannula, and then eventually we can get down into the ball of the silicone. Now the cannula that I use, I fully agree that the traditional liposuction cannulas don't work. That's why I went to the liposuction cannula companies and said, hey, I need one specifically formulated for me to suction out silicone. Now this is not a liposuction cannula or that I use for the silicone. The one that I use is slightly smaller, but it's custom made, but this is just for this lecture. So the evolution of this closed technique has become this ultrasound guided, Vaser-assisted silicone scar suction. You can see right here, there's no mention of liposuction. Okay, this is silicone scar suction. We're not lipoing fat, we're lipoing scar tissue, again, around that silicoma, and then the silicone that's underneath it. So we're just hitting that section just underneath the skin to get rid of that silicone and associated scar tissue. It's kind of a thin plane in this patient, but I've isolated it with the ultrasound. You saw it. I melted it with the Vaser to make my job easier here. And now we're just chiseling away at the silicone and the scar tissue to get this patient's symptoms away. You know, this patient has buttock pain, redness of the skin, radiation of pain down the legs. So a whole host of problems. So we got to get this silicone out, but the patient did not want, absolutely no way, an incision across the top of the buttock.
Rolling.
So these are some of the bigger ones we took out here today. You can see that these are just little things filled with silicone. Pretty firm balls. I mean, I can't even get it through there with a scalpel. And that's the silicone that's inside. So there's one. There's another fairly bigger one. I'm going to cut in through that. And you can see by getting into that, then it spills its silicone. So here's another one. These are pretty thick. So there's all the silicone residuals, so all these bobas. And then you can see from the specimen, this is what we sucked out here today. There's millions and millions of these little silicone balls, those little clear little spheres. That's all silicone. So look at all these hundreds and hundreds. Here's one, here's one, here's one, here's one, the big ones. And then you can just see they're all scattered throughout the specimen. So does Vaser suction work? Absolutely yes. Look at all these silicone balls throughout here. They're everywhere. Hundreds and hundreds of them. So does this work? Does this technique work? Absolutely, 100%. And saves the patient a scar, saves a threatened buttock implant, and there we go. So it's mutated into this thing called ultrasound-guided Vaser-assisted silicone scar suction, or USG-VA-SSS. And again, it's not liposuction, and a lot of patients will question, well, if we're doing suction, aren't we just spreading the product around? Well, no. I'll show you on a lot of videos and a lot of patients, the product that we suck out, I spread it out on the table. You can see the silicone and the scar tissue that we remove. It's not that we just go in and we suck out fat and we spread all this silicone out. No, we're actually sucking it out. So the analogy that I use there is when you're vacuuming your carpet, you do spread some dust, but 99% of the dust is sucked out through the straw, through the liposuction cannula. So with the open technique, what we try to do is I try to make the incision closest to the area that has the maximum amount of the silicone. Usually people have the center of the buttock injected, and most people have excess scar tissue and these granulomas and silicomas in the center of the butt and in the top third of the buttock. Some patients have it in the lower third, but usually it's in the middle third and the upper third. So there are 9 different types of incisions that I do for patients to get rid of the silicone. So the most common incision that I make is at the top of the buttock here, across the top, here, and here. My patients call it a seagull incision or a McDonald's sign incision. The second most common area that we do is in the vertical crease right there, the vertical buttock cleft. And the third most common that we do is underneath the buttock. The more rare incision that we do is out over the hip, where we make an incision like that. So those are the 4 most common. 1, 2, 3, 4, and of course they're matched on the other side. And then we sometimes have to combine these incisions on more complicated cases where there's more skin and tissue that needs to be cut out. So another combination that we do is from across the top and down the buttock cleft. Sometimes it's down the buttock cleft and underneath the buttock. Sometimes it's underneath the buttock and up the side, and sometimes we go up the side and across the top, and of course match it out with the other side. So that's 4 initial cuts, 4 secondary cuts, that's 8 incisions, and the more rare is an incision that goes straight across the buttock. Those usually are reserved for revisions or patients that have been seen by other plastic surgeons where they didn't get out as much product as we want, but that incision comes straight across the buttock. Another common problem that the silicone causes is this thing called ASIA syndrome. Now, ASIA stands as an acronym for Autoimmune Inflammatory Syndrome Induced by Adjuvants. That's where the ASIA stands for. And the adjuvants are things like silicone, like aluminum, like infections. Anything that stimulates your immune system can stimulate reaction by your body. And in this case, we're talking about silicone. So ASIA syndrome is fairly specific. You have to be exposed to something, infection, silicone, adjuvants, things that stimulate your immune system. And then you have to have repercussions from it. There are major criteria and there are minor criteria. The major ones, myalgias, myositis, muscle weakness, your muscles hurt. Arthralgias and arthritis, your joints hurt. Chronic fatigue, you're tired, you have brain fog, you're exhausted all the time. You wake up in the morning and you're still tired. Unrefreshed sleep disturbances, you can't sleep well at night. Neurologic impairment, memory loss is very common. Dry mouth is also very common because of that histamine reaction. Sometimes we'll actually even get a biopsy of the affected area, but usually we know it's the silicone and we know it needs to be removed. So looking at the closed technique, which is that suction technique, the surgery takes about 3 hours. I do it under general anesthesia. You're completely asleep. You will not wake up during the surgery. You will wake up at the end of the surgery. And I have you wear these compression garments, which really help with the swelling and the healing. And I have you wear these compression garments for about 6 weeks. And the recovery is about 1 to 2 weeks. You're usually able to return to a work type job at about 1 to 2 weeks. If you have a very active job, maybe it's going to be about 2 to 3 weeks. And usually most of the swelling is gone at about 4 to 6 weeks. Most patients have some kind of pain, but the pain usually wears off after about a week to 10 days. With the closed technique, there are basically 3 incisions, one at the top of the buttock crack and one underneath each buttock cheek. And they're about the size of a grain of rice to get to that area. And then I can crisscross the area. I sometimes use drains on the buttocks when we're using the closed technique with suction because the amount of material and the amount of fluid that's coming out. But that we really tell on the table. Not all patients require drains. If you do get drains, they usually don't stay in too long, maybe 5 to 7 days. And I encourage you to sit on the buttock right after the suction technique because that helps with the swelling. It also helps get rid of the fluid. It helps with the healing, and it helps with the initial scar tissue to sort of start to rebuild. With the closed technique, I allow you to start exercising usually at about 2 weeks. You can have intercourse usually at about 2 weeks if everything is healing right. I encourage massages usually after about 2 weeks, and I have you wear that compression garment for, again, about 4 to 6 weeks, depending on the swelling. And then usually once everything is healed, then I have you put the scar cream on to minimize the scarring at about 2 weeks. In contrast, the open technique is a much bigger procedure. It takes longer to perform, and the recovery is longer because it's more invasive. The procedure, the closed technique, again, takes about 3 hours versus the open technique, which takes about 4 to 5 hours because we have that longer incision. I'm resecting skin and sometimes muscle. I'm peeling out the nerve. It's done under general anesthesia, just as the ultrasound Vaser-guided suction is. You wear the garments for about 6 to 8 weeks, depending on the swelling, longer if you have swelling, and the recovery takes about 2 to 3 weeks. If you have a sitting job, maybe you're returning to the sitting job at about 4 to 6 weeks. If you have a very active job, maybe you're returning to work at about 4 to 6 weeks. And usually the swelling is gone at about 6 to 8 weeks, depending on the patient. You will have pain, but most of the pain should start to dissipate or go down, usually at about 1 to 2 weeks. Now, where else do I see this silicone being injected? Well, I've had patients who've had it injected into their temples, their brow, the malar or cheek region, the nasolabial folds, the lips, the uppers and lowers, the biceps, the triceps, the pecs, the female breast we've had it injected to, the hips, the labia, the scrotum, the penis, the thighs, the calves, pretty much seen it all over. And then to make it even more complicated, as we talked about, this stuff moves all throughout your body too. So a lot of patients will ask me after their either closed technique or their open technique, when can I have reconstruction done? Well, it's very important for you to heal from the first surgery before you go and have a second surgery. So one, all the swelling has to be gone, all the healing has to be gone, and usually you've got to give yourself at least a good 4 to 6 months to heal up from either the closed technique or the open technique for your body to be able to heal from the second technique. Your body is constantly making these new blood vessels into this area, bringing healing blood cells to the area, making initial scar, and the initial scar changes into a more mature, soft scar. So you got to let that whole process go for about 4 to 6 months. So one very common question I get from my patients is, will I need reconstruction? And that's a very important question because a lot of the time we don't know until the surgery is completed. Okay, you've got to really understand that the silicone and the granuloma, the scar tissue around it, need to be removed. So these are reduction surgeries. I'm taking away, I'm subtracting, I'm making this area smaller. Okay, it's not going to be the same size, it's going to be smaller. It's not going to be bigger, it's going to be smaller. I'm taking tissue away. So it's a very important concept for you as a patient to realize that what I'm removing is silicone and scar tissue, so therefore that area will get smaller. Most of my patients are content, happy with a smaller buttock, but some do need reconstruction. Okay, so once we realize that it's going to be a reduction surgery, the reconstruction really depends on what you desire. And basically I've boiled it down to this mathematical formula. A plus B minus C equals D asterisk. Okay, so A is the amount of the product that's been injected. Was it a little? Was it a lot? Only you and your injector know how much was injected. B is the amount of scar tissue, this pink stuff around the silicone, that was created and what your body reacted to. C is the amount of product that I removed. So this is what you show up with, the silicone and the scar tissue, okay? I'm going to be taking out a lot of the stuff, most of the stuff, and D will be your result. Okay, so that is what it is. For some patient, their D is X and they're very happy with it and off they go and they don't need any reconstruction. For some patients, that D is too small, their buttock is too small and they need reconstruction, they want reconstruction. So therefore we go ahead with reconstruction. Now one of the problems is a lot of the time we don't know what A is. We don't know how much is injected. Number two, we don't know how much scar tissue there is. But we do know C, how much I resect, I picture it, I weigh it, I make a volumetric analysis. But D, that's probably maybe the more important value, and the asterisk is really the most important thing, what you want your buttock to look like when we're done. So there are three ways to reconstruct the buttock. One, I use your own fat. People call it a Brazilian butt lift or BBL. Typically I get fat from the abdomen, love handles, lower back, any place we can find it, inner thighs, and then transfer it to the buttock. That's a nice way to go because a lot of people have extra fat. Two, it's your own tissue, so you're not going to reject it. And then three, you get the best of both worlds. You take away fat from an area you don't want it, and then two, you reconstruct the buttock. Another very good way to reconstruct the buttock is with FDA-approved buttock implants. Very good way to go. There are multiple different shapes and sizes. It's perfectly safe. These buttock implants are nothing like the silicone that's injected. There's also another product called Sculptra. Sculptra is injected. It's another FDA-approved product. But the Sculptra we inject usually in the office, and it helps to grow collagen. It makes new tissue in the buttock to increase the size of the buttock. So thanks for joining. We welcome questions from our audience, and we would love you to pose any questions to us, and we can get them answered.
Okay, user 292 asks, why do you think it's so important for people to have big butts these days?
It's more of a cultural trend. In the US, maybe in the early 70s, 80s, and 90s, many women were getting breast implants, breast augmentation, and now the trend, at least in the US, is for bigger buttocks. So it's a social trend that we're seeing more and more of in the US and worldwide, of people wanting bigger butts. So it's very important, in my opinion, that you be very happy with your own body and not go on these social trends and these influencer trends. You should be happy with yourself and your own body.
I Love Drafts asked, did you invent the closed technique?
Yeah, the closed technique I've been working on for about 20 years. So, you know, I tried liposuction initially. That didn't work. So I said, how could I make it better? So then I started using the ultrasound. Still, it wasn't quite where I wanted it, so I added that layer of the Vaser. And still, it wasn't getting the results that I wanted, so then I had the cannula specifically formulated for me. So yes, I guess I did invent the ultrasound-guided Vaser-assisted silicone scar suction.
Okay. Fluffy Dog 86 asks, is it possible to do the closed technique under local anesthesia?
No, both the closed and the open technique are done under general anesthesia. You're completely asleep, and I use board-certified MD doctor anesthesiologist. It's too painful under local, it's too painful under IV sedation. Go to sleep, let me do my job, wake up, and we're done.
Jasmine 50 asks, why was creating the closed technique so important to you?
Yeah, the closed technique took about 20 years to perfect, and it was very important to me because a lot of patients come to the office and they're like, look, you know, I cannot have that big incision. I just don't have the time to take off from work. I can't live with that scar. My job is of a sort where I cannot have a scar like that. So I counsel these patients, well, maybe you can't have the bigger incision, but at least we get a large majority of the product out with the suction technique. So it does offer a lot of patients who would otherwise never have the surgery, leave in all that silicone, leave in all that scar tissue, an opportunity to get rid of most of that silicone with the suction.
Mr. Jared asks, Doctor, I want the closed technique, but I have silicone that migrated into my thighs. Is it possible for me to get the closed?
Yeah, very good question. So if the silicone or granulomas are in the gluteus maximus muscle, you really need the incision. But if it's above the gluteus maximus muscle, and with those criteria that I mentioned, it is possible to have this suction technique. And if this stuff has migrated down into the thighs, it really depends. Is it in the fat and is it small? Then we can come in with the suction. But if it's a large lump or a large granuloma or a ball, we may have to make an incision, either a little bit or a lot, to get that product out.
Happy Girl asks, how do I get insurance to cover this? Do you think there's a chance of them covering it?
So very, very good question. So unfortunately, a lot of insurances do not cover silicone removal, but it really depends on the quality of your insurance. If you have really good health insurance, it is possible that this is covered, and I've had patients who have this covered. On the flip side of that, I do have patients who do not have good health insurance, and these procedures are not covered.
User 0503 asks, will I still be able to wear a bikini after this?
So what I try to do is when I position the scar, I try to position the scar under reasonable clothing. But the most important take-home message of these surgeries is to get the product out. Now that's the most important thing, not necessarily being able to wear a bikini. So you got to get the silicone out, you got to get the scar tissue out. Secondarily, if you need it, you may need buttock reconstruction, the stuff we inject, the Sculptra, the fat through a Brazilian butt lift, or the buttock implant. And then you can wear clothes. But the being able to wear clothes, what we do is we try to hide the scar in the clothing.
16 Mama Bear says, I'm trying to convince my daughter to get her silicone removed. She's afraid of having a smaller butt. Please send her a message.
I would tell her that it's very important that you get the silicone and the granulomas and the silicomas out as soon as you can. So you got to realize that a lot of these patients who have silicone injected into the buttock are very ashamed of their injections and their appearance. So a lot of people don't tell others about their silicone that's been injected. So it's sort of a topic that really isn't mentioned. So I would counsel your daughter to tell her she's not alone. There are a lot of people that have had silicone injections. A lot of people have been treated by me and others. And this silicone needs to be removed. So she's not alone, but she really needs to seek out a specialist that specializes in silicone removal and subsequent reconstruction. So if you have silicone, get it out. The sooner the better. Don't wait till you have problems and complications, both systemically or locally. Get it out as soon as you can. A lot of people have silicone. A lot of people have gone through the surgery successfully, and then they've gotten rid of the majority, if not all, of the silicone, and they do very well, and they're very happy and live without a lot of pain. So if you're having problems with silicone, give me a call. So thank you very much, and have a great evening.